Hot flushes, brain fog, intimacy struggles, menopause symptoms can be tough on their own, but after cancer, they can feel overwhelming. Today, Dani Binnington and I explore the symptoms women face after treatment, the challenges with intimacy that no one talks about, and the treatment options, including the evidence on HRT. Welcome to All About You. I'm Dr. Shauna Watts, GP and women's health advocate. Each week, I bring you evidence-based conversations to empower you through midlife. If you joined us last time, you'll know Dani and I shared our personal stories of early menopause and the reality of not only the physical but emotional impacts it can have on your life. Today, we're focusing on what happens next, covering how to navigate symptoms of menopause after cancer, the treatment options that are available, including the important discussion of hormone replacement therapy and sexual health after cancer. Remember, this is general information only, not personal medical advice. Please consult your healthcare provider for personalised guidance. If you joined us for episode 1, you'll know that Dani Binnington's story is both deeply personal and incredibly powerful. She shared how her cancer diagnosis and treatment triggered early menopause and the overlooked emotional impact that came with it. Today, Dani is back with us for a second episode. She's not just sharing her own journey, she's also a voice for the thousands of women in her menopause and cancer community, many of whom have shared their stories of frustration, resilience, and hope. Research conducted by Menopause and Cancer, Dani's not-for-profit organisation, in a community survey found that 90% of people were not given any plan to manage menopause-related health changes after treatment. Only 1% had a clear plan in place. Yes, 1%. 75% received little to no information about how cancer treatment could affect hormone health or fertility, and a staggering 99% believe there should be better supports in place. 9 in 10 said symptoms significantly impact their quality of life, and 3 in 4 said these symptoms were harder to manage than cancer itself. These numbers tell us this isn't a niche or a specific geographical location problem. It's a system-wide gap in care. Yeah, so as you've alluded to, not everyone has that sort of gap between cancer treatment and then having menopause symptoms. For some people, it all happens in a big mess of treatment, and it does seem, I have to say, as a doctor, it is unfortunate that some of my colleagues definitely don't address this in probably the way they should. And I think a lot of women are made to feel if they ask too many questions, well, kind of get a bit of a pat in the hand and just say, look, the main priority is that you don't have cancer anymore. And, the next thing the person's swept along, and before they know it, they can be absolutely knee deep in hellish menopause symptoms. And I'm sure there are many women in your community who've maybe not been too bad. And then there's others who've had absolutely horrendous symptoms, but with often no pre-warning. Is that what you're hearing?
What I then realized by having access to brilliant people myself, I then thought, I still want to know how to eat, how to exercise for a menopausal body. I thought, can I take collagen with a history of cancer? I thought, what about creatine? But there's always a but, isn't it? And then the normal menopause conversation talks about something that cancer survivor will think, but is it safe for me? So I then set up the Menopause and Cancer podcast, and every week for nearly 200 weeks, I brought a doctor onto the show to teach us their expertise, because I thought there are so many people in the dark. But what happened? I got too many emails from people saying, Dani, it's great information, but I'm still in such a bad situation. I don't know what to do. And so I decided to set up the Menopause and Cancer not-for-profit organization. And since 2022, we've supported thousands of people online and in person. And we've recently done a really big research survey with a couple of hospitals here in the UK, and the results were really shocking. So over 90% of people said they had no pre-cancer menopause treatment plan. All of them were put into the menopause because of either chemotherapy, surgery. Many of them are on endocrine therapy for hormone-sensitive cancers. Many of them had stem cell transplants, for example, or radiotherapy, no ovarian function. for the majority of them, like over 75% of them, they said that the menopausal symptoms were worse than their active cancer treatment. And by 2050, we'll be talking about 16.3 million women diagnosed with cancer. Up to 90% of them will be affected by temporary or permanent menopause because of their cancer treatment. So we're talking millions of people that will have a very, very reduced quality of life and long-term health implications if no one helps them with their menopause. And so it's the pandemic of really cancer survivorship going forward.
Absolutely. And it's definitely the conversation that needs to happen so much more openly. And I do wonder sometimes why the conversation isn't had. Does the doctor feel like they don't want to bombard the person with some more bad news, or they don't want to give them something more to worry about? But the reality is that, we have to stop being kind of paternalistic, and we have to let people have the information that they're entitled to have. And of course, we'll then get to the next barrier, which is so many people still being stuck with the whole, if you've had cancer, particularly breast cancer, then hormone therapy is absolutely off the agenda. And so many doctors remain very, very scared of hormone replacement therapy. What was your experience with that? And what about your community right now? What are they telling you about those conversations?
People aren't getting the conversation. It's not how the conversations go. People have no one to have these conversations with. That is the problem. And just last week, and when people listen to this, it'll be a little while longer, we launched the world's first World Menopause and Cancer Day, which is going to be brilliant going forward. It was a huge media campaign. We reached over 37 million people here in the UK with this conversation, which is brilliant. But again, people are telling us they did not get a conversation. And on many radio interviews, people ask me, why is it? Why is no one talking about it? A bit like you said, do doctors do they have not enough time? Do they not want to share more bad news? Is it maybe too much? When is the right time to talk to a patient about it? But actually, when you think of the system globally, the reason menopause management for cancer survivors falls through the cracks because oncology is set up to save our lives and to prescribe drugs that save our lives. And many of these cancer treatments make people menopausal. There is no room anywhere for helping people manage the long-term side effects of that cancer treatment, that collateral damage. It doesn't exist in any cancer services globally. However, there are some people that reached out to us over the last couple of years. They have survivorship programs. And in these survivorship programs, sometimes there are menopause programs, but it's very specific when there is a brilliant doctor or a brilliant nurse that's got it on her or his radar or their radar. And then you're discharged into primary care. And then you realize, oh gosh, I think my cancer treatment left me menopausal, or I have a lot of symptoms of the menopause. And then we're too specific a case to be dealt with in primary care because our poor general practitioners, I understand, you suddenly come with like pages and pages and pages of documents from your oncology teams. It's really difficult to know how can you help these people safely, which is why we need a lot more education for healthcare professionals, but we also need to weave in the hormonal health, the menopause impact into cancer services. But people tell us they don't get the conversation. There's little time in oncology. They're either told to just, well, that's the thing, you're on endocrine therapy, take the little white tablet for 5 to 10 years. Most people are fine on it. Not correct. Correct for some, but not correct for all. And then they go to their GP and their GP thinks they're too specialist a case, so people fall through the cracks. And what we need is that conversation.
I've had a number of patients in the last 4 to 6 weeks who have all had breast cancer and some other cancers who've actually told me that their menopause symptoms were actually the worst part of their entire journey. I've had patients who have been so depressed and so anxious that they've been suicidal. I've had patients who literally have been unable to sleep at all for years and convinced that they've got dementia because their brain fog is so bad, and they've literally got to the point where they're like, look, at this point, even if someone's telling me I can't have these hormones, my quality of life right now is so, like, the reality for me is my quality of life is so poor that it doesn't feel like it's worth living, versus a potential theoretical risk of a cancer coming back. And I think the conversation around hormones and cancer has to become very personalized, and it's definitely nuanced. And yet over and over I see women who have just had the conversation shut down before it even starts.
Yeah.
Doctors refusing to even discuss it. I've even had patients tell me that they've literally been fired by their doctor. So their doctor said, if you're going to do this, I'm not going to look after you anymore. And so we're definitely at this really challenging time in medicine where the hangover effects of the WHI study continue to influence decisions massively, and there seems to be a great disservice being done.
What can you do? What do you do with these patients? I mean, as a doctor, you just want to help people, right, Shauna? It's that's why you go into this profession, and it's these stories that you just mentioned. We hear hundreds of them, hundreds every single month, of people coming to our workshops, of people telling us on our walks and talks how they feel. And all we try and do is find a network of a community or a community of doctors so they can have conversations about all treatment options available to them. How does your conversation go with these patients?
I obviously just want to treat that person as an individual. I try very hard to get their oncology team or whoever's looking after them on board. And I have to say, to be fair, so far I've been really quite lucky. I've actually had patients from all over Australia, and I've sent off studies to people. I've even encouraged some doctors to read some books, and then they've come back and had another conversation with me. And we have let the patient take control, because at the end of the day, it is that person's choice. And a lot of the time, the patients have chosen to take some menopausal hormone therapy. I mean, even just thinking of, for example, vaginal hormones, like the difference that those can make for someone who's, literally having UTIs all the time. They can barely wear, tight clothes or jeans or tights or stockings to the gym. Everything feels too tight. They feel uncomfortable. Being intimate is almost impossible for them. And yet, you can actually turn around someone's life with this incredibly low dose, incredibly safe for the vast majority of people, and actually just not to have that awful bladder pain or urethral pain, or to be able to have an intimate relationship. It's actually life-changing for someone who already feels like their cancer has robbed them of so many other things, and then for them to develop all these awful symptoms that they're having days from work, or they, as I say, they can't have a relationship, or they're constantly having to know where the bathroom is. And I think, I just try very, very hard to think about the person in front of me and think about what the reality for them is. And sometimes as doctors, we are scared of something that might happen, but I think we have to live in what the reality is for that person. And of course, there's people on the other end of the spectrum who take their endocrine therapy and they cope really okay. But I have to say, in my experience, they are the minority, and a lot of women really struggle with this treatment. And sometimes it seems like the conversation has been just like, oh, well, you just have to take this tamoxifen and you're going to have to take it for 5 years or whatever it happens to be. And it's all very matter of fact. But suddenly, a couple of months in, these women are like going, this is horrendous. And I had actually no idea what to expect. And I think that we just have to do better. And it is fantastic, like, that organizations like yourselves are really empowering women, because I think that as individuals, if more women are educated and will just say, well, hold on, I actually want to talk this through, and I want to understand what really are my risks. And, even just giving people the choice, I think has to be a bit more of what goes on.
I love all of that. In fact, we could bubble all of this up and just put you into people's pockets wherever they are. I want to just tap into 3 myths that you have just addressed here. And the biggest one myth that many breast cancer, let's stick with breast cancer for a moment, many breast cancer patients tell us is they say, when active cancer treatment is done, you're done. And that's a huge myth, because for the majority of people, the endocrine therapy, and that affects over 70% of all breast cancer patients, is the biggest issue. And when you think back to what I said earlier, when I was a young patient, there was an end to my active cancer treatment. I knew how many rounds of chemo, I kind of knew how many rounds of radiotherapy, there was an end to it. With the menopause, there's no end. Once I'm in surgically onset menopause, I'll be in menopause forever. But also for people on endocrine therapy, 5-10 years is a very, very long time. And we can do really well and work really hard for shorter periods of time, but no one can do really well and work really hard and do all of the things when they're feeling absolutely awful for 10 years. It will burn you out. You need support. And so the biggest myth there is it's active cancer treatment is a thing, but then the endocrine therapy is a huge thing to add to that. And then to really talk about hormones, I think every cancer patient's conversation around menopause should start with hormones, regardless of who you are. Because what we see in our organization at Menopause and Cancer, we look after patients after all different types of cancers. So bowel, brain, breast, gynecological cancers. And many cancers can vary. After many cancers, you can very safely have hormone replacement therapy. Of course, there is more to you and you might have some other contraindications. But after many types of cancer, menopause hormone therapy is a really safe option. And so many people that we look after are in their 20s and 30s, for example. They're pushed into the menopause because of their cancer treatment. And because, like I said earlier, menopause is not in cancer services woven in, these people fall through the cracks. So suddenly we have a whole group of, say, 50 young people, all in their 30s, all of them in menopause, and none of them have been offered menopause hormone therapy. Or if they have been offered it, they've all been given a generic dose that isn't appropriate for them. And so the conversation needs to be, is menopause hormone therapy safe for me? What are my risks? What's the difference between systemic and local hormone therapy? And if it isn't the first line treatment, it's important to open up all of the other treatment options, because we now get a lot of people coming in saying, I think I need menopause hormone therapy because otherwise my long-term health is just going to be bad, bad, bad. And they have such a worry about their long-term health because of all of the narrative out there in the media. And what we always say, we say, look, it's important to say that early menopause has a negative effect on your long-term health. It can negatively affect your bones, your heart, okay? But then it's also about saying, what can we do about it? Let's help you look after your long-term health. And often when people have a plan, they feel looked after, they feel their medical team is helping them look after the long-term health, they feel more in control. And suddenly they're like, okay, actually, maybe menopause hormone therapy isn't my only option to help me look after my long-term health. And so it's really, truly understanding, why do people come with their questions? What makes them tick? Just recently, I went to a workshop and there was a huge group, 80 breast cancer patients. And one lady was so lovely. And she said, I've done so well. I'm over 10 years on. I've completed all of my active cancer treatment. I did so well. I had tamoxifen for 10 years. I did it all. But I recently went for a smear and my doctor couldn't perform the smear. They couldn't enter because of my vaginal atrophy is so bad. And so her doctor said, you can never have vaginal hormones. You just can't ever have a smear test again. And it broke her heart because this person really wanted to look after her future health after everything she's been through. She felt awful that she couldn't have another smear test. She thought, wow, I'm in my early 60s and now I can't look after and maybe prevent a gynecological cancer. It didn't make any sense to her. And of course, we now know she was given incorrect advice. For a breast cancer patient who is no longer on any treatment, we know vaginal estrogen is absolutely a possibility and a must to help her with these symptoms. It makes no sense to maybe not screen her for cervical cancer just because she was in so much pain. And so those are the other myths that we really need to bust. And the huge myth about the safety of vaginal estrogen is one we can't talk enough about because it comes up in every conversation.
And imagine this poor lady who you're talking about. Not only can she not tolerate having a speculum put into her vagina to do a pap smear, but we can almost assume that there's no way she's able to have an intimate relationship if she wants to, because it would be excruciating, obviously. And, this is a frustrating reality for so many women, particularly those who've had cancer treatments. I know there's this campaign in the USA to remove the warning label from vaginal estrogen, and we have the same in our boxes here in Australia. And it's so annoying and it's so frustrating because it's such a low dose, it's so safe, and yet it is absolutely life-changing. And imagine, being a woman of 30 or 40 or 50 or 60 and someone just saying, oh, well, sorry, that bit of your life's over. Bad luck for that. Like, it's just not okay.
Yeah, it's not okay. Luckily, with vaginal estrogen, there is lots of new data that has come out over the last many years and lots of the international societies. So I always like to go up and look at the entire world and see what's going on. And you look at the Australian position statements and Canada, US, Great Britain, and you look at all of the position statements. And it's very clear now that vaginal estrogen is safe for breast cancer survivors. In the past, there was a little bit of controversy for those who are on an aromatase inhibitor. But we also know it's really important for all of those patients to have a conversation about their own risks and benefits. And in the majority of cases, their benefits will really outweigh the risks. Because when you speak to patients, and we know that from a lot of data and research as well, many patients will stop the endocrine therapy for breast cancer because of GSM symptoms, so genitourinary syndrome of menopause, and their joint ache. And so those are the two really bad symptoms why often people say, I can't do this, I feel so horrific, I'm going to stop my endocrine therapy. And so to some doctors who are reluctant to prescribe maybe vaginal estrogen, would always like to say, if you think of the whole person, if you say no to vaginal estrogen to help your patient, are you okay for your patient to stop the endocrine therapy? Let's look, and in a non-judgmental way, because let's look at all the pros and all the cons of anything you do, because nothing ever just comes with benefits apart from exercise, I guess, right? But it's important to look at the bigger picture, because those are the conversations we have with women every single day. They come to us and they're like, and this whole person, I've got all of these thoughts. And then when you sort of unpick, you're like, okay, for some people, their benefit of endocrine therapy is, say, 2%. For others, it's much higher, say 12%. Every patient can then say, okay, all of these side effects are worth it for me. And for some doctors, they will say, look, your endocrine therapy benefits are so great. Let's do anything to help you stay on those treatments. And what people often say to us is they have to make those decisions alone. And that's what we don't want. We don't want patients to sit at home, not being able to get the conversation, then having to go and seek Dr. Google or private health or other expertise. We want patients to be able to have those conversations with their doctors. And the same goes for weight gain, for example. There are so many people who come to us and say, gosh, I've been piling on the weight since surgical menopause or since menopause because of endocrine therapy. Surely my risks of a recurrence are really going up because I'm now 3 stone overweight. And so you've got to balance it all out, right? The treatment, your lifestyle, everything falls into the equation. And it's important to look at us as a whole body and not just the boobs, the ovaries, or the isolated body part. Because when I speak to survivors, we live in our whole body with our mind every single day. And that's what affects us.
Yeah, absolutely. Not just a set of breasts. Dani, we've talked a bit about the the issues around, so I suppose the medical community, some of them not being completely up to date. And of course, it's hard to stay abreast of everything. But what about the misconceptions and the fears that remain within the population at large? What are the things that your community are still believing around hormone therapy and cancer? Do the majority of people, when they come to you, still think that if you've had cancer, then there's no hormone therapy?
I think by the time they come to us and they engage in workshops where we know about them, where they tell us their stories, they've usually gone on a little bit of a journey. So it's often younger people. I just recently spoke to someone and she's had a rare type of cancer actually in her teens, and her medical team put her onto a dose of hormone therapy. But that was it, no follow-up. She didn't know what menopause was. She didn't know all of the symptoms. In the 3-4 years after her very grueling active cancer treatment, many of her symptoms were getting worse. Her brain fog, her night sweats, her hot flushes, her insomnia, her terrible vaginal dryness, and the pain. She described the pain down below so severe she couldn't even sit her exams in school because she was such a young patient. And when she then found the help through self-advocacy, it's because she realized a lot of these symptoms weren't to do with her cancer treatment. They were actually to do with the menopause. So all these years, this young patient was thinking, surely my symptoms will get better with time the longer away I get from my active cancer treatment. But in her case, her symptoms were just getting worse. And what she really needed to work on is find someone to prescribe her the right type of menopause therapy for her age, for her symptoms. And she wasn't getting that. She just said, no one in my oncology team spoke about it. I just walked away with a pill. Apparently these were hormones, and it wasn't right for her. She needed better information. So for her, it was all about accessing the right treatment for her. Many people after different types of cancers, brain tumors, bowel cancers, leukemia, for example, they say it takes them about 2.5 years to access menopause hormone therapy. Because when they're first discharged, no one talks about menopause or hormones. And then it takes them a long time to talk to their GP. And then the GP says, I'm not quite sure what's safe for you. Let's refer you back to gynecology. And often that referral process takes a long time. So we know in average, a couple of years go by until these people who can safely access menopause hormone therapy, it takes them too long. So the mission there is to bring the menopause conversation into cancer clinics so that perhaps on their discharge papers, their GPs can be empowered and their GPs could be told this person is a good candidate for HRT should they struggle or should the conversation come up. So that waiting time gets reduced. We don't need millions for that. People often say, Dani, in an ideal world, do we need billions? Do we need a healthcare reform? I'm like, no.
Yeah, so
couple
of lines at the end of the specialist letter would make such a difference. Ladies, are you feeling flat, foggy, or like you've lost touch with who you used to be? Well, it's time to rediscover you. After 25 plus years as a doctor working with women as a GP, an aesthetic doctor, and in women's health, I've created the 16-week Rediscover You program to help you reclaim your energy, confidence, and vitality. This guided, evidence-based journey is specifically designed to support you through the perimenopause and menopause. Together, we'll reset your hormones, boost your energy levels, create sustainable weight management, and restore the clarity and glow you deserve. We'll take a deep dive into what's really happening inside your body, from hormonal shifts and skin changes to disrupted sleep patterns and mood swings. You'll get the tools and understanding to navigate the powerful transition with confidence, clarity, and care, because you deserve to feel like you again. Our waitlist is now open. Click the link in the show notes to save your place. When it comes to hormone replacement therapy after cancer, the conversation is often shaped more by fear than by facts. To really understand the evidence, I want to share insights from a 2022 review published by Dr. Avram Blooming and colleagues, one of the most comprehensive looks at the topic to date. This publication pulls together decades of research, and it reminds us that the story of hormone replacement therapy is far more nuanced than many of us have been led to believe. Decades of studies have consistently demonstrated the benefits of HRT: relief of menopausal symptoms, improved cardiac health, lower risk of hip fracture, slowing of cognitive decline, and even enhanced longevity. There are risks, however, particularly blood clots with oral HRT, though we don't see the same risk with the transdermal forms that we now use. The most sensitive question is breast cancer. Between 1980 and 2013, 25 studies examined HRT use after breast cancer, with 20 reviews published since. Only one study, the Habits trial, showed an increased risk of recurrence, and even then it was limited to local or contralateral or opposite breast cancers, not distant spread. Importantly, none of the studies, including the Habits trial, showed an increased risk of breast cancer mortality or death. In fact, the Habits trial found just 22 additional cases of local recurrence linked to HRT. And yet, based on those 22 women, millions of breast cancer survivors worldwide are denied HRT, despite its proven benefits for so many aspects of health and well-being. This does not mean HRT is safe for everyone or that it's a simple decision, but it does mean the conversation deserves nuance. Women need balanced, evidence-based discussions with their healthcare providers and not blanket bans. Dani, I know you have this amazing community of women who've at various stages of their journey, and I have so many women who feel broken and guilty because of the loss of their intimate relationship, and they just feel so worried about what's going to happen, and is their partner going to leave them, and they feel so upset by what has happened. Are there any tools or products or therapies that your community kind of swear by or that have helped people outside of vaginal hormones that you might be able to talk to?
I'm going to say this is one of the hardest things to tackle, and one of the things that takes the longest, and one of the things that people struggle the most. And I'm going to read you out something that came up in our community recently. Someone said, I've been with my partner for almost 30 years, and it's been 10 years since my cancer. I was started on tamoxifen, so the little white pill, the endocrine therapy. My libido disappeared. It's challenging enough in a long-term relationship with kids and work, but this has really nailed things. We just don't. It really distresses me and probably him, and no idea how to move forward. We don't talk about it either. It's the giant elephant in the room. And other people say, my partner and I had really good sex life before cancer 8 years ago. After the treatment, surgeries, and now on endocrine therapy, I have zero libido. My cancer was hormone-driven, so I can't even consider testosterone or HRT. I know it bothers my husband. He's not been demanding, but has recently expressed that he feels I don't find him attractive. I've tried to explain why I'm like this, but it doesn't change the fact of the impact on our relationship. I wish I could change it. We have hundreds of messages like that. And sometimes just by being able to say, even as an anonymous member in our Facebook group, it helps you feel that you're less alone because we don't talk about it. In many of our workshops and conversations, we talk about sexual health. We talk about becoming comfortable. So really getting on top of your dry vagina, vulva, any of the sort of physical symptoms, that's a must. Because if you're uncomfortable, you're not going to want to engage in pleasure. Many people talk about really rediscovering sex and that it's not all about penis and vagina sex. We know that. But I'm not going to give you a quick fix because I don't think there is one. It's been years of deeply engaging with people on this level. We've spoken to numerous psychosexual therapists. It's tricky. It usually starts with the self. It's maybe self-pleasure, it's touch. And many psychosexual therapists have explained to me, for me personally as well, they said, Dani, if you feel unsafe in your body, it's very difficult for you to then feel aroused, to be stimulated, because you need to move into that lovely parasympathetic part of your nervous system to feel aroused, to enjoy pleasure, to become intimate. And when you're scared and heightened in your sort of anxieties, it's going to be tricky. So it's super multifaceted. It's super tricky, but I think if anyone is interested in knowing more, trying to change where they're at, it's bringing the conversations into your life. Listen to sex podcasts. You know, there are brilliant podcasts just on pleasure, intimacy. Work on yourself first, because I think a lot of it is directed to our partners and because that relationship has changed. But I think most psychosexual therapists have said to me, Dani, it starts with you. It's easier said than done, because if you're not bothered, Shauna, you're not bothered. I know what it's like, but
Dani, thank
it's a
you
tough
for
one.
helping me address that very difficult conversation. I know we're nearly out of time, but I just want to squeeze another question or two out of you if I can. What about the women who cannot and just cannot, whether they absolutely cannot have hormones or they just cannot let themselves have hormones? What are the other things that your community find really helpful? I know you've talked about how exercise and movement has been so important to you. Is there good evidence behind this?
There is good evidence behind a lot of other things. You know, like we have good evidence that menopause hormone therapy helps, of course. We have good evidence for acupuncture, especially for cancer survivors. For other complementary therapies, there is good evidence for other non-hormonal prescribable options for their benefits. Does all of it work for everyone? Nope. Does all of it just come with benefits? Nope. But the same is true for any medication you prescribe as a doctor, right? But I think it always comes back to what can you do for yourself and what can your doctor do for you? And every day you can do something for yourself that will help you a little bit, whether that's having a sleep for 10 minutes or a quick meditation at lunchtime because you're out of energy, whether that's a really lovely cup of tea and you just switch off and you chill out, a little walk, whatever it is that feeds you and is good for you, you can do that every day. No one has to eat, you know, just green plates and smoothies and drink their green teas nonstop. But there are little gestures we can do that will make us feel better. And then it's understanding what your doctor can do for you. And I have put everything that we have evidence for into my book called Navigating Menopause After Cancer, which was published a few weeks ago. Is it a couple of months ago now? And with the help of many, many doctors, we've pulled together everything that people can do, including hormones and also all of the other strategies. What can your GP prescribe you? What medication helps for what symptom? What complementary therapies are there? Are there actually benefits to what type of exercise? What types of food help with what menopausal symptoms? You know, it's been years of bringing all of these experts onto my podcast, and I just felt like everywhere I went, people still had the same questions. So I thought I need to bundle it all up and put it into a guide. And so Navigating Menopause After Cancer has all of it in it. And I will review it every single year because there are new options coming out, like the new non-hormonal options for hot flushes, for example. So we've got to keep moving with it. Will all of this mean that people will suddenly walk away with no menopausal symptoms after cancer? No, sadly. But can it help people improve how they're feeling? Absolutely. And I think it's really important to make people understand that they've got options, whatever they are, whatever you feel you want to do, whether you want to throw yourself into your lifestyle or whether you want to go knocking on your doctor's door. There is always something you can try, because the worst is to sit at home and think you haven't got any options.
Dani, thank you so much for choosing to share your story publicly, for writing your incredible book, which we have all the details of in our show notes. So hopefully we can get our patients and listeners onto that. And I also wanted just to thank you for being open to having some difficult conversations and opening up a bit of a chat about things that people do feel scared to bring up in their consultations. They often can feel a little bit rushed when they're talking to the doctor. They know the doctor's maybe running late or running behind, and they feel like they don't want to waste someone's time. And as you also so rightly said, there are always options, and we need people to realize that they're not alone. Tell us how our listeners can find your community, which sounds like it is going to be an awesome resource for even our listeners who are in Australia, America, and all around the world.
Yeah, we have loads of lovely Australian and New Zealand members in our Facebook group, for example. So that's the Menopause and Cancer Chat Hub. And everyone learns differently and wants information differently. So you might want to jump into the Facebook group, or you might just want to go onto our website, menopauseandcancer.org. And from there, you'll find all of the help and support that we have to offer. And whether you want to just plug yourself in and listen to podcasts or watch our YouTubes or join the Facebook group, or maybe just sit and read the book. And maybe when you're ready, you can engage with others in the Facebook group. It's when you're ready. And one thing I do know, people go on a little journey when they come and find our organization. It's digesting what's happened to you. It's making sense that your cancer treatment has made you menopausal, and that's probably shaped the course of your life in many different ways. And it is our aim to help you claw back a little bit of that control and really support you. Like you've said so beautifully earlier, it's really supporting the individual, and every individual comes to us with a different passion, a different role, that they've got their own questions they want answering, and it's for us to help them find the safety of the solutions, the evidence base, and help them do their research so that they can feel empowered to go for it, because we all deserve to live a good quality of life after cancer, and I think together we can really help each other do that. And so we need doctors like yourself have the conversation with their patients. And I do know the more you bring it up with your doctors, everyone listening, whatever it is that you're experiencing, the more your doctors are going to think, gosh, we can't ignore this any longer. And the more doctors are going to think, okay, we need to help our patients with better solutions. We're going to influence research. We're going to influence how cancer drugs are done. So imagine the next generation of people on this planet could live with cancer drugs that do not make them menopausal, for example, like they make us now. We have the power to do that as a community. I know it.
100%. And I think, there's nothing as motivating to a doctor as the patient knowing more than we do about something. So I encourage everyone to go in, ask lots of questions, because hopefully, even if you know more the first time, hopefully the second time you go in, the doctor will have gone away and read up and be feeling much more confident and comfortable. Dani, thank you so much. I have loved this conversation, and I could continue. I know you're in a rush to get away, so I appreciate you very much.
Shauna, thank you so much for having this conversation. We love you for it. It's amazing. Thank you for all you do.
So here are my 3 takeaways from today's conversation with Dani Binnington. Menopause after cancer is under-recognized and often described as being worse than the cancer journey itself. Hormone replacement therapy isn't a closed door for all women after cancer. Every woman deserves a clear, balanced discussion of all treatment options. And sexual health is part of whole health, and women deserve the space and opportunities to have an honest conversation about it. Thank you for listening to All About You. If you found this conversation helpful, the best way you can support the show is by following All About You wherever you listen to your podcasts. And if you'd like to help other women discover this podcast, please take a moment to leave a review. Your feedback not only helps us grow, but also ensures more women get access to trusted, evidence-based health information in midlife. You can also check the show notes for resources from Dani and her menopause and cancer community. Until next time, I'm Dr. Shauna Watts, reminding you that informed health decisions start with you.